we talked a little bit about unmet needs, and let's talk some more about that. So how do we get at this nausea problem? So the CIN field has basically looked at complete response as the endpoint. Complete response is a construct for our audience defined as no emesis and no use of rescue medication in 5 days. That's how we define success from a regulatory perspective. And that's not how we define the success from taking care of patients.
And people should recognize why. I think, you know, when you're trying to have a study and you want to show endpoints, you want something that you can measure. And so I think that's really where that came from. So complete response being, you know, no vomiting, which you can measure,
right,
and not using those meds, which
right,
you can measure, but that's not necessarily what is patient-centered or patient-focused.
So can we measure nausea? What do you think?
I mean, it's once again, it's so subjective. It's whatever the patient says it is.
So as Charles said, maybe our bar should be no nausea. Some studies use no significant nausea, but what does that mean? It means marking on a visual analog scale less than 25 on 100.
I mean, unfortunately, I think nausea is going to be here to stay for a while until we come up with that perfect drug that takes care of everything.
Right, but we do have about 70% control for the AC, and probably a little higher for platinum, we think. So there's still a residual 30–40% there.
Well, I think it's a bit more on the nausea. If you go 5 days
right,
of no nausea, I think it's probably only 30%. With the standard 3-drug regimen, it's probably more like 30%. But I think, can we measure it? I think, yes, we can measure it, just like we can measure pain, what the patient says it is, and I think it can be differentiated from being hungry or being or just not. And just like we can measure hot flashes by asking, do you have hot flashes or not? And study after study after study show that the same drug works the same. So yes, these are measurable things. It's not perfect, but again, Rudy Navarri's been the main person pushing this thing. No nausea is probably the best thing if you can get no nausea.
So you're an expert in measuring subjective findings from patients. So can you measure differences between patient groups? So even if nausea is interpreted a little different, can you measure a benefit? Is the benefit similar if in a different patient, whether they experience nausea a little different? If you see a percentage benefit, in other words, a drug helps a particular condition.
So I think if you have groups of patients, you can measure these things, but for individual patients, it can be harder. But as a group, yes. And I think that studies that have looked at this thing show similar results with different groups of patients. So yes, but each individual patient might have a different perspective, and you're not going to get 100% on things. But yes, I think you can measure changes in pain, hot flashes, mouth sores, all these things. Patient-reported outcome is the new terminology for many of these things, and that's what it is. And it's best for them to write it down daily, as opposed to trying to summarize it 2 weeks later by talking to the doctor or the nurse.
I always worry about scales like nausea, just the variability even in regions. Certain offices you just see different responses from a nausea in a 50–60 mile an hour radius.
You think that's conditioning of patients, or
I don't
do you think that's different population? We do see that these trials that are run globally, we see differences from different parts of the world, and that may be cultural and it may be physiologic and pharmacogenomic. We just don't know the answer to that yet. What about other?
You need to make sure you're measuring the same way, different practice, how you ask the question, that sort of thing.
So what are other unmet needs in CINV?
So I think, Charles mentioned the multi-day, which is huge. So we don't know if you're getting, even low or moderate metagenic chemotherapy for several days in a row, if that should be treated by just taking the worst offender of those and making sure your prophylaxis is treated that way, and then how often do you dose them? And I think a huge unmet need in that setting is our hematologic malignancies. I mean, these are patients that frequently are getting that multi-day, and when you ask our transplanters, there's wide variation on how they're approaching this issue.
And they're always on the drugs that interact with these agents as
well. Bingo. Yes.
And not to denigrate that group, but when you think about what are you focused on for a transplanter, it's about giving the drugs and getting the right therapy in. It's not so much about supportive care, right? So it's been a little bit neglected.
Although there was an abstract presented at this meeting on early palliative care for patients getting transplant versus standard care, and illustrating that their symptoms were better controlled when you had somebody who was focused on that, while the transplant doctor is focusing on trying to cure the cancer and somebody else focusing on that. You do have better quality of life and better symptom control in that setting too.
So that just extends what we already know. Early palliative care is better for everyone, right? And whether you have an advanced cancer and whether you're curative or even in the palliative setting, as we know.
Yeah.
So I think another, what's been an unmet need for a very, very long time are pediatric patients.
Yeah.
And recently, I think it's Unmet that's been approved for peds, and there are more studies that are being conducted, fortunately, for pediatric patients now to help them. I mean, it's been more than 30 years, really. They're not little human beings, and so we've been treating them as such with what's been available.
Right, and we don't have any pediatric oncologists on the panel today, but
Yeah,
I think I'm
that's a
glad you
shame.
brought that up
Yeah.
because it is clearly an unmet need.
Yeah.
And many of the drugs that they receive in very aggressive curative regimens are highly emetogenic, so we
Definitely.
definitely need more studies there. Also brought up radiation, and I think that's also an unmet need, particularly as we do more combined modality therapy. So seeing some studies now around that, I think, is important as well.
I think
The
we
other
also
thing-
mentioned, I'm sorry.
Oh, you go ahead.
I think we also mentioned the high-dose chemotherapy and the conditioning for patients who are about to undergo transplantation. That's a difficult group of patients to treat as well.